Thank you both for those excellent presentations. I'm hoping everyone is able to see the speakers as well as myself. I don't quite know Zoom land. And I just wanted to start off asking a couple of questions of both speakers. And I'll ask it to the two of you and then rotate between you. First of all, can you talk a little bit about whether avoided visits are actually the right primary outcome that we want? And I appreciated it in the second presentation, you mentioned that with any sort of tele-intervention, you get some of that already. And these added interventions might not see added reduction, but just talk a little bit about that issue, whether there are concerns about negative effects of reduced visits and just the complexity of that. I completely understand why it's something we put in our studies. It's very important to measure. We all understand the implications for cost, but would like to hear from both speakers a bit on that. So one of you jump in. Yeah.
Sure,
ahead,
I'm happy to start. Sam. Hi, everyone. Thank you again for the invitation to speak today. So I think that it only includes for the obvious reasons, but I agree with you that I think there are some other outcomes that we view as more important in our primary outcomes. We're very interested in how patient behavior is changing, both around the practice of taking medication, adhering to complex oral chemotherapy regimens, but then also in terms of the behavior and reporting their own symptoms and then triaging their symptoms within the care team. So I think that those outcomes are the primary ones that we're interested in. And there are myriad issues with the issue of potentially avoidable and unplanned acute care. I agree with that.
Yeah, and I'll just add, I totally agree with Sam. I think the other thing that I would add to that, though, is that it's also about, I see this as a way to empower patients, so engaging them. And so it's less of a passive model of, I have to wait to see if the doctor tells me if I'm okay. I think there's psychological benefits there to, in my own area in breast reconstruction, I think, I believe this idea of sort of empowering patients by giving them information that they are able to interpret and that it becomes more of a bidirectional information highway.
Thank you. Another showing my technical side, so we won't spend too much time there, is I'm curious if you can say a little bit about how you trained your algorithms or when you launched. Did you have sort of a Wizard of Oz where there was a human being monitoring the advice and the feedback as both a safety mechanism and a training mechanism? So Andrea, why don't you start in?
Sure. I would say, actually, once we started, post-surgical patients are a little bit different. I'm just speaking first to the MSK program. There were definitely some endpoints that clinically just made sense. So, shortness of breath, moderate shortness of breath anytime after ambulatory surgery. That was once we dug into it, we realized we didn't actually need algorithms for every. There was a lot of things that were just fever. So it actually was really just pain and fatigue that were the ones that really needed the data. And so we did wait till we had the data on that from other patients, but a lot of it was just sort of the clinical, just clinical common sense.
Sam?
Sure. So we are working with two industry partners to develop sort of two different versions of Penny, if you will, and we've approached this differently, I think, with each partner, but both of them have had a sort of, for a period of time, in particular during beta testing, a fake backend where there's a clinician available to review the communications between patients and the bot to make sure that the bot is triaging appropriately, interpreting appropriately. If the bot gets stuck and doesn't understand what the patient is saying, that we adjust a machine learning engine. There's learning from each of those times that a human needs to intervene to put the bot on the right path. An example that Larry likes to tell, who was involved in this project intimately, is that of during the Super Bowl when the Eagles were on their ascent to the Super Bowl. There was a lot of pro Eagles, go Eagles into the chatbot, and the chatbot didn't really know what to do with that. So I think though that speaks to the fact that this, even though patients knew that this was an automated chatbot, there was a sort of humanization of it, and they really viewed it as this companion on a journey with them through their cancer care.
So I'm so happy you told that story, because there's a rather more detailed question I wanted to ask you that I was holding back, not thinking it was a general interest, but here I go. So I have a wonderful doctoral student whose title of her thesis is Illusions of Empathy. And I'm really curious how you thought through and think about how much of this human-like characteristic to bring to the chatbot, how much you understand that it increases engagement, which is a good thing, otherwise you wouldn't have built the tool, and how much you wonder if at times it adds to misunderstanding, and how far do we go in that perspective. I don't think that that the other application that Andrea talked about has as much, it looks like an app and a tool. It doesn't as much look like a conversational agent.
Thank you for that question. I think this is critical, and it's not something that we have fully unpacked or evaluated, but I have some thoughts, and I will also say that we are heading in the direction of more rigorously evaluating this with qualitative and mixed methods research. So I think the human feel of Penny has always been an important part of its secret sauce. And we've heard that anecdotally from patients that, again, knowing that this is an automated chatbot, still they feel as if 24 hours a day they have someone that they can text or something that they can text that responds back to them immediately, validates their concern, helps them sometimes to more precisely characterize and to communicate that to their care team. That's the first point. The second point is that I think we have learned from Ethan Bash and others that to maintain high levels of patient-reported outcome reporting, we need to give something back to patients in return for that information. We need to use that information as clinicians to help tailor the care that we're giving to patients. And if we don't do that, we've seen them, and I think it's the second ingredient that baked into our design, which is that we do give patients something back. And whether it's the human feel or the companionship or the empathy, as you put it, or whether it's, again, just facilitating better communication with their clinical teams, I don't know. But we in the sort of phase 2, as I call it, we have baked in really rigorous mixed methods and in particular qualitative research to understand exactly these questions.
That's great. And just before I go to some questions we have on the chat, I think both of your examples in both of these talks were clearly focused on giving something back. They didn't look like an excuse to get data back to the clinician. And I think that's shown in your results, shown through in your results as well. Okay, so we have a question from Doug Peterson, University of Connecticut Health. To what extent can the telemedicine algorithms be tailored to address levels of patient health literacy as well as language and cultural diversity? So I think that's really for either or both speakers.
I mean, I'll jump in a little bit on that, Deb. I think it's a really interesting, exciting, and important area, and so that's. I think I don't have the answer to it, but it's something I'm actively really working on now with our improved breast cancer care program. We specifically built it with a view as our next studies will be to work with other institutions nationally that have completely different patient populations than what we see in Boston. And my hope is that systems like this can be culturally modified, can have the diversity, can have the cultural diversity in the language to make it such that they can actually provide care in places that actually don't have the ability to provide this level of care and can be an extender in different settings. But I think and I'm excited to study that.
In digital health, we've seen for a long time that one of the biggest digital divides is one of age. I imagine that in your area, you have what is the distribution of age, and how do your older users compare to your younger ones?
I would say, Deb, what we've actually found, so we've, all the work, the one thing I would take away from the work that we've done is that the qualitative work, and Sam's spoken to this as well, qualitative work to sort of keep figuring out if you're getting it right. And so we have focused on making sure that we have that older individual. And I would say we have a fantastic PFAC here in Boston that has been really super engaged. And they are a certain demographic, and they give really blunt feedback, and it's been super helpful. And they're older women, and but we're building something they like as well. And I think that's I think we need to build things that work for all these different demographics.
That's wonderful. Maybe for sake of time, I'll go on to the next question. And it's for both speakers. So Sam, I'll ask you to start with it. It's from Rebecca Shear. How did you incentivize patients to fill out PROs, whether mobile or some other format? And we've seen so many of our patients, especially newly diagnosed, feeling overwhelmed. And so asking them to do yet another thing is difficult. I'm paraphrasing. And they've tried direct and passive and all sorts of things. So just there's that. Sam?
Sure. I'll just mention, just to clarify, that our effort with Penny is actually separate from Penn's effort toward robust or rigorous PRO monitoring and routine care. The symptoms that we're eliciting, we do try to, the bot iterates with the patient and tries to categorize it within the PRO version of the CTCAE. So it tries to sort of grade a symptom, if you will, on the back end, but the patients are reporting free text however they feel, and then the bot on the back end is really iterating. And again, I would just say that there's no direct incentivization for reporting other than a little bit of sort of behavioral economics nudges and things built into the platform to try to make it easy for them to report. But the real reason that we're getting them to report through the through Penny is that we give them something back. I really believe that part of it, as I said earlier.
Wonderful. Just before, go ahead, Andrea.
I think I was one of the things that we've built with the improved system has been to embed longitudinal surveys, and we particularly something called the ICHOM, the International Consortium of Health Outcome Measurement. We have ICHOM all the way through, and that can be burdensome to patients. It is my hope, but this will be to be determined. So we've loaded Improve with so many different resources and things that they can do. That giving back idea that Sam has so nicely stated. I'm hoping that will increase our compliance and that essentially the giving patients something, the incentivizing patients to engage with the system and give us and then provide the PRO data that we actually really very much need, not just for clinical care, but for quality and value.
And so we'll be heading over to the next panel in just a couple of minutes, but if either of you have any last comments about where you're hoping to take this, you can take it, leave it, your call.
I just want to mention, I saw a few comments come through the chat regarding ethical issues surrounding this kind of communication with patients. And I just want to sort of mention that we are treading cautiously. We're hopeful that this is, we're hopeful, but we're also wary that we need to be rigorous in our understanding of both the ethical issues and the other issues that were raised.
Wonderful. Thank you both very much. And we look forward to the next session.